Now, with acute kidney injury, a very important algorithm or flowchart that becomes important is what you're seeing here. Now, I'm going to walk you through some of the important parts with specifically acute kidney injury. But keep in mind, though, at some point in time, would you have azotemia part of your chronic renal failure as well? Absolutely. All right, so with azotemia here, you're going to take a look at your urinalysis. You're going to do an ultrasound. When you do an ultrasound, you end up finding hydronephrosis. So now you have a kidney issue. Find hydronephrosis, then now you're looking for obstruction. You find your obstruction, move to the right there. Diagnosis, post-renal azotemia. Diagnosis, kidney stone. Maybe it was BPH, older patient. Hydronephrosis, you don't find obstruction, then you start looking at, your renal size, and you start doing urinalysis. With urinalysis, what are you going to do? Well, you might find the following. You might find, let's say a smaller kidney, negative for sediment, and you end up finding what's known as isotenuria. And your protein is less than 3.5 grams per day. Ladies and gentlemen, this would be chronic renal failure. And we'll walk into this a lot more in detail. Isotenuria, what does that mean to you? You've lost the ability to properly concentrate the urine and down in the loop. And so therefore the type of urine that you end up producing will be iso. There's no variation. That's not good. You should be able to concentrate the urine. You should be able to dilute the urine. But the fact that you're producing isotenuria along with these other issues with negative sediments, and I'll give you a bunch more symptoms in which we'll walk through chronic renal failure big time. You know, in our society, one of the most common causes of chronic renal failure is your, diabetes mellitus, or diabetic nephropathy. Okay, now, let's say that you have a normal size, and this time, though, there's going to be cortical thickness. Upon further urinalysis, you find, we'll talk about the abnormalities, and we have, when we looked at, what if it was bacteria? If it's bacteria, you're thinking about what kind of CAS? WBC CAS. And you find this to be neutrophils, then you know it's pyelonephritis. Next, what if you find your WBC CAS made up of eosinophils? Then you're thinking about interstitial nephritis. What if you find RBCs, RBC CAS? Well, now you're thinking about issues with maybe kidney and maybe nephritic syndrome. With RBCs itself, maybe it's some type of vascular occlusion. And if you do find your RBC CAS plus your protein, then you should be thinking along the lines of nephritic glomerulonephritis or maybe perhaps even vasculitis. That's a brief little rundown of the different types of abnormalities and urinalysis that we've discussed earlier. Let's take a look at what happened here. And you find normal urinalysis, but now you start thinking about urine electrolytes. So what does this mean to you? Well, pay attention, if you find your fractional excretion of sodium to be decreased, you tell me what kind of azotemia. You have oliguria, less than 400 milliliters of urine being produced per day, and you find your fractional excretion of sodium to be decreased. That's pre-renal azotemia, isn't it? What does that mean? Remember our discussion. Your renin will be stimulated. Aldosterone works in a normal kidney, or at this point normal. It's reabsorbing your sodium. Fractional excretion of sodium will be decreased. Less than 1%. That's what your focus should be on. Now we have pre-renal azotemia. And hopefully you're able to get in there and address the issue ASAP. But if you cannot, and the pre-renal azotemia continues, you then end up causing ischemic acute tubular necrosis or ischemic type of acute kidney injury. Here you find your fractional excretion to be increased. And greater than 2% is what we said. So this puts you in the realm of acute kidney injury, acute renal failure. Nice little overview of chronic renal failure, acute renal failure that we just talked about with the different phases, and then all of the different type of pathologies that we talked about in nephrology in brief. Obviously, details are required, and we had these discussions in our respective topics. Let's move on, please.